we leave on time, but we will have some take-home messages, and my intent is not to give you details about a particular salt or a particular drug or a particular antibiotic, but I am going to tell you about the basic concepts by which you can easily modify your outcomes or therapeutic outcomes. Okay, when we talk about antimicrobial pharmacodynamics, what do we understand by antimicrobial pharmacodynamics? Well, let us say pharmacodynamics of antihypertensives, that we know that it has to bring down the blood pressure. What are antimicrobial pharmacodynamics? That it has to kill the bacteria. That is the dynamic effect of the drug. Now, how it is and how good it is at killing the bacteria, that is antibacterial pharmacodynamics. Whether it is doing the killing of the bacteria is dependent on the concentration or total concentration, or whether it is dependent on the time for which it is available in the in and around the bacteria. That is time dependent killing and concentration dependent killing. These are the two basic things. Or whether it is the cumulative action, which is area under curve over MIC. Now, if you are familiar with these three concepts of AU, concentration dependent killing, time dependent killing, and AUC related and exposure related killing, you would have come across that all these things are covered, are discussed in context of MIC level values. That how much time it is above the MIC, how much times it is above the concentration is more than MIC. Now, is MIC a good indicator? Let's have a discussion about that. Is MIC is actually a good parameter to define all these things, or there are some things which can be something which are happening differently in the body, and what we are seeing as a concentration in plasma and MIC are something which is totally different. Let's have a brief discussion for a few minutes on these two aspects. Is MIC based reporting or MIC based modification of therapy is a good idea for a clinician, or we need to think differently in this situation? Now, what is MIC? Minimum inhibitory concentration. It is a lab parameter. It is lab parameter, and the bacteria is on a culture plate. We put different concentrations or disk of antibiotics, and we see how much the bacterial growth is inhibited. So that is MIC. It does not consider the fluctuations in antibiotic concentrations that we see actually in the body. In the body, the concentration changes. And when we talk about bacterial infection, we want the antibiotic to be there at the site of infection, not in bloodstream. If it is changing in the bloodstream, definitely it is changing at the site of infection also. So bacteria in the body is exposed to totally a variable sort of concentration of the and changing concentration and dynamic concentration of antibiotics. Second thing, does MIC based reporting take into consideration the immune status of the individual? It does not. Again, if the patient is immunocompetent, he might require lesser doses of antibiotic even for a resistant organism, because his immune system is also working, and development of resistance to body's immune system is a great possibility. So these are the two things that you should keep in mind, that MIC based reporting, and another fallacy of MIC based reporting is that MIC reports are for one individual agent. It is sensitive, intermediate, or resistant to a particular antibiotic. It does not check whether the combinations can be given or not. It does not give the report if you are using combinations of antibiotics. So that is another thing which is a fallacy of modifying the regimes or its selection of antibiotic or just on the basis of MIC based reporting. You can go for combinations. Now, what all combinations can be used, what all combinations cannot be used, that you need to see in literature before you start prescribing. The basic concept is, which you would have read in pharmacology, which you might not remember just now when you are in post-graduation, is do not combine static with cidal drugs. I hope you remember that principle. Now, bacteriostatic with bactericidal drugs should not be combined. Now, can you name some bacteriostatic drugs? This is PG question. No? Name two classes of drugs which are bacteriostatic, not bactericidal. Guesswork? तो कहीं मार दो यार. which you use in OPD setting, outpatient settings, probably, which we use in community care settings or in outpatient management of the patients. Sidal action is more important or static action is more important? Relevant, I would say. Important to चलो दोनों ही है, but which is more relevant? If the patient is being managed in outpatient setting, that means patient has not deteriorated to a life-threatening situation. His body is still responding. So even if the drug has got a bacteriostatic action, body's immune system will be able to take care of that. It will be supported by the use of antibiotics. So which is the drug which you use for let us say upper respiratory tract infection? The choice of antibiotics for URTI. यार अब तो पीजी करके आए हो यार, अब तो एग्जाम क्लियर किया है. Outpatient management of erythromycin. Okay.
Is it sidal or static?
हाँ तो पता था तो macrolides. Okay, one class. Static. Okay. Next, any other drug? Ampicillin, amoxicillin तो देते हैं ना?
Cell wall inhibitors. So if you inhibit the cell, it will be static or
sidal.
You will kill the cell and the cell will destroy, then automatically will destroy.
Quinolones, again the very commonly used class of antibiotics. Sidal or static?
You are killing the RNA DNA material.
DNA damage होगा तो मर ही जाएगा ना बेचारा वो, उसके बाद क्या बचेगा? So it is sidal, definitely it is sidal. Now the question is, just check in your clinical practice. How many of you have seen use of erythromycin with cefotaxime or other beta-lactams? IV. Just a question, just recall your prescriptions. Now, I am not telling you that this is a wrong combination, but I am telling you that the principles should be supported by evidence also. The basic principle is do not combine static with sidal drugs. Macrolides are considered to be static. Beta-lactams are considered to be sidal. But we are regularly combining this combination and giving it through IV route. Yes or no? Very commonly. Do we have the evidence supporting it or not? Or nobody has tried to look into the evidence? This is the third option, like MCQ. Yes, no, we have not seen or not applicable. So in this case, actually evidence is supporting. I told you that this principle is there, but principle should be supported by evidence. Evidence is in favor, a lot of evidence is available for use of this combination. Now, what is the reason for this thing? We do not know. You would have seen a lot of drugs, the combination of beta-lactam with aminoglycosides. Is it an appropriate combination or inappropriate combination? Beta-lactam, piperacillin, tazobactam, or with amikacin, gentamicin. You have seen such, you have prescribed, definitely. This is absolutely right combination. Now, we move further with this kind of overview. Now we move further into this problem statement. There was a patient with ventilator-associated pneumonia, already on multiple antibiotics, and the response to treatment is suboptimal, which is not as per your expectations. So what are the possibilities for a suboptimal response? Whether the diagnosis is right, and again, when the referrals that Dr. Khushbu showed, most of them had pan resistance. Whether the sample was collected properly or not, the suspicion of the infection and the labs was supporting or not, whether there are other diagnoses or not, whether the lab has given the right results or not, and the interpretation in terms of whether the antimicrobial therapy needs to be modified or not. We need to see the whole picture before for investigating suboptimal response. And then only we should blame the antimicrobial therapy or modify the antimicrobial therapy itself. Now, what are the variables which affect the response to antimicrobials? First is definitely the infecting organism. Now, MIC values and cutoffs are defined for every organism separately. People in microbiology will know about that, clinicians will not. Then comes the inoculum size. Bigger the inoculum size, more antibiotic will be definitely will be required. Smaller the inoculum, and then the level of resistance, that is the inherent capacity of the organism, followed by site of infection. Infections of bones and other sites and loculated sites, definitely they will require prolonged use of antibiotics in some either relatively higher doses. Then comes the dose, which has to be given. Now, the dose defining is on the basis of the antimicrobial pharmacodynamics for most of the time. Otherwise, there are standardized doses. Then clearance of the drug. How much drug antibiotic administered is being removed from the body. In case of renal failure, everything is getting accumulated. So we should be happy with it that antibiotic is staying and the body is working like a antibiotic. The whole body is antibiotic, kind of. And in those situations, we need to reduce the frequency of the dosing. Then protein binding. Now, this is an interesting aspect in terms of you all know from your basic knowledge about pharmacology or any that it is the free drug which is active. Protein bound formulation drug is not active. It needs to get into the free status. So if the drug is highly protein bound, it is going to stay in the tissues for longer period or for shorter period? Logic, absolute logic. Drug with high protein binding is going to stay in the tissues for a longer period or a shorter period. And if it is going to stay for, I'm talking about tissues, I'm not talking about blood or the plasma levels. It is going to stay there for a longer period of time. And if it is going to stay there for a longer period of time, relatively, now you might be getting confused. अगर वो ब्लड से ही फ्री नहीं होगी, ब्लड प्रोटीन प्लाज्मा प्रोटीन से फ्री नहीं होगी तो टिश्यू में जाएगी कैसे? This could be your logic, na? But when it is bound to tissues, it will act locally for a prolonged period of time. This is what we see when we are using carbapenems. They have got good protein binding, and then they have a prolonged duration of action. Okay. Then comes the dosing regime. Dosing regime is how frequently and how much. For how long? These are the three things. How much, how frequently, and for how long. If the drug has got higher binding to the sites and if it is getting concentrated in the tissues, drugs which have got a higher lipid solubility, they are going to stay in the tissue for a longer period of time. We might omit few doses. We might switch them to oral things early. Then comes immune status of the individual and the other comorbidities. Now, these are the two variables basically where clinical judgment is required, where no pharmacological principle is going to work. It is the comorbidities and the probability of patient responding appropriately or not. That is purely clinical judgment. And then you can definitely, pharmacology will not work in those situations or any modeling will not work in those situations. Now, one open question. What is your opinion presently that antibiotics have got a wide therapeutic index or they have got narrow therapeutic index? Just two options. Leaving aside few exceptions which you already know, like vancomycin, you will tell them, or aminoglycosides. Antibiotics in general have got a wide therapeutic index or narrow therapeutic index. They have wide therapeutic index. And if they have got wide therapeutic index, should you be worried about the ADRs? If they have got wide safety margin, what should be your concern? It is primarily the response to the patient, how the patient is responding or not in terms of bacterial clearance, not in terms of whether he is developing headaches or not, or he is developing vomiting or not. So your primary concern should be the antibacterial efficacy of the drug, except for few situations where the drugs have got narrow therapeutic index, which is aminoglycosides or vancomycin. Beta-lactam class, pretty safe. You don't have to be worried much about the ADR. They definitely increase seizure potential, and this could be one of the concerns in ICU settings, where but in ICU settings you have already sedated the patient. Patient is already sedated. So think on those terms also whenever you are planning your antibacterial regime, because bacterial killing is more important than ADRs, except for few situations. Now, in this case, we have a drug exposure and rate of resistance development. Now, rate of resistance development, can we somehow increase the rate of resistance development of antibacterial resistance if we use the drug inappropriately in tertiary care centers, or the resistance actually develops in peripheral centers when the antibiotics are used inappropriately? What is your opinion? Let us say we have given suboptimal dose of the drug. Bacteria is likely to develop some mutant survival, like we all know, some mutant is going to survive. What is the probability of the development of such resistance in tertiary care settings, in our settings, but as compared to the probability in community care setting? It is more in community care setting where inappropriate medication use is rampant. In our situation, the problem comes because of inappropriate hospital infection control policies. If a mutant develops, it stays. It stays. And it remains there. So the incidence rate will be higher. So that is what we need to see. Now we come to the basics of PKPD of antibacterial, antimicrobials. One parameter is minimum inhibitory concentration. Other parameter is minimum bactericidal concentration. And the third parameter, which is relatively new, is mutant prevention concentration. So MIC, all of us are aware. MBC, all of us are aware. Mutant prevention concentration is the threshold above which selective proliferation of resistant mutants is expected to occur only rarely. That may not be MIC, that may not be MBC. But mutant prevention concentration, these cutoffs have not yet been defined. But maybe during our lifetime, we will always see that mutant prevention concentration cutoffs are defined. Now, what is PKPD analysis for antibacterial? We have pharmacokinetic data. Okay. Then we have pharmacodynamic information which is available and the patient characteristics. So these are PKPD analysis. This is what it integrates. What is the reason for this analysis is that to enhance the effect of antibiotics. That is the only aim of PKPD analysis, and to prevent emergence of resistance. So these are the aims. Okay. Now, what are the PKPD indices? We have concentration dependent killing pattern, which is where the relevant parameter is Cmax to MIC. Then we have time dependent killing pattern, where time above MIC is relevant, and then we have a cumulative factor where AUC over MIC is the relevant parameter. So, what are the antibiotics which have got concentration dependent killing and time dependent killing? These things you should know, and on the basis of which you can design your regime. Concentration dependent killing is seen with aminoglycoside, quinolones, metronidazole. Remember these three, because these three are most commonly used antibiotics in our situation. Aminoglycosides, fluoroquinolones, metronidazole, azithromycin, and glycopeptides. So these are the drugs which are got concentration dependent killing, where peak is more relevant. Then the other class of the drug where time over MIC is relevant is beta-lactam, primarily these four classes. And macrolides, you might see azithromycin here and macrolides there, it belongs to the same class. Practically, macrolides are followed the time dependent killing pattern. Azithromycin is an exception. So that is why we have a formulation which is IV azithromycin is available, which gives high peak. Then we have clindamycin, glycyl cycline. So basically, these are the antibiotics which have got time-dependent killing pattern. Now, this is a oversimplification of antimicrobial pharmacodynamics. The pharmacodynamic parameter is dependent on the drug and the bug combination. It is not primarily a general principle, or it does not apply to all the situations. Now, if you are seeing a concentration-dependent killing for Pseudomonas, it may not be the same for Streptococcus pneumoniae. It may have different pattern. Now, again, this is adding to the confusion. Ultimately, and we do not have the database, but primarily, this is the simplified form of understanding the antimicrobial dosing regime development. Then we will not discuss all that. Okay. Okay. Now from this table itself, how do we give antibiotics? We define a dose From where do you get the dose? Either from what your seniors tell you or what is available in the literature or whatever you get from up to date. You find a dose and you start giving the patient the dose. Usually, what is the practice in our situation is if the infusion is given over, for which drug do you give?
Let me ask them. Because in dermatology, have you given acromegaly flavor? Amikacin. No. Which antibiotic are commonly? Injection or oral? Nothing about what? So injection is recently advice. How do you? So we give 1.2 gram antidepressant twice weeks. How is it of the babies? That's only because we advise that the nurses to be really slow and extremely slowly. Because at least 1 hour to 2 hours. Any other medicine people? How you are giving subtracting over 1 hour? Over 90 minutes, 1.5. Someone is 30 minutes? Which department? PMR. You are giving 30 minutes. Anyone else? You must be giving subtracting there or supervisor. Peptides. So peptides you are giving in over how much hours? When you are writing, if you are not writing, then you are just writing IBPDS, let nursing officer decide. Practically the answer is let nursing officer decides.
That was actually I was coming to.
And you have getting it? Getting over.
So
answer are actually very vague and then Dr. Puneet will answer.
Now actually this is the point which I want to highlight. There are drugs which have got concentration dependent killing and some drugs which have got time dependent killing. For the drugs which have got time dependent killing, which includes carbapenems, the first thing, the infusion should be given over 3 hours. Because if we are giving out over a period of 3 hours, it is going to sustain the levels at least for 3 hours above MIC, significantly high levels. And the duration for which it will be at a higher level will remain longer. So carbapenems and we discussed something about protein binding also. And carbapenems have got significant protein binding. So they are going to stay in the tissues for a longer period of time. Their action will be prolonged. Now, contrast to this situation when we talk about aminoglycosides. Aminoglycosides have got concentration dependent killing. And quinolones, they have got a concentration dependent killing where peak is more important. Peak in terms of how much high we are giving it. So giving it in high doses over a shorter duration of infusion will be more helpful. So depending on the class of the drug, you need to select your regime. So for concentration dependent killing, increase the rate of infusion, increase the dose because this will achieve the maximum killing. For time dependent killing, increase the duration of infusion. Now the question is whether meropenem 1 gram or 2 grams. What if you are giving meropenem 1 gram and you replace it with meropenem 2 gram? Because the solution will be higher, no? Volume to be infused will be higher and it will cover the period of infusion. Ideally, if you look at the what is documented in many literatures, is that if you give the infusion, continuous infusion of meropenem, that is the most efficacious. Carbapenem, that is the most efficacious because it is concentration, it shows concentration dependent killing. Time dependent killing. So if it is time dependent killing, rate of infusion can be increased. What if, now my question was, what if you are increasing the concentration also? Is it going to harm the patient? Or is it going to lead to development of resistance? Or it is not going to have any effect but can lead to better treatment outcomes. Remember, we are talking about time dependent killing with meropenem. Meropenem 1 gram over 3 hours versus meropenem 2 grams over 3 hours, which is a better regime in terms of therapeutic outcomes. If the patient is not in a life-threatening situation. 1 gram meropenem over 3 hours is sufficient. If you increase the dose to 2 gram meropenem over 3 hours, response is expected to be better because meropenem, they are sidal drugs. Patient is in life-threatening situation. We want to kill the infection properly, absolutely. Carbapenem as a class has got a wider therapeutic index. You should not be worried about expanding the ADR. It is the patient's life which is more important than some kind of other kind of issue, adverse event. So you can always modify the dose within the recommended range. You can go to the higher range. For concentration, for time-dependent killing, increase the rate of infusion. Please note that increase the rate of infusion for time-dependent.
If you are not writing in your prescription, I don't think nursing staff will. And who are here, even if you are 50, who are here, whenever you are going to practice from today onwards, please, all the right side of this paper, please write over 3 hours. Whether you are taking 0.5 gram, 1 gram, 2 gram, depending on the drug types or the dose type based on what you get. Write the infusion. Otherwise, nothing happens. TDS doesn't mean anything. Or QID or OD doesn't mean anything to the nursing. They will come and just post it and just IV push. Ceftriaxone they will take 2 grams ceftriaxone over slow infusion over 10 minutes. Then when you will ask actually, आपने क्या किया? No, I have given infusion, slowly. How much time? And 10 minutes.
Practically, no antibiotic is given.
I am getting everywhere. So you have to write early because you are a physician and you are the leader of the patient. You have to write injection ceftriaxone 2 gram or 1 gram, whatever dose is for the body type. Then over 3 hours. Then write in the right hand TDS or 6 hours. Normally TDS for the oral doses, and you have to write for the hour basis for the IV or 6 hour or 12 hour or 10.
Another thing about concentrated drugs which have got concentration dependent killing is we should be giving loading dose also, which is relevant in case of IV. Levofloxacin is quite commonly used, and for levofloxacin, giving loading dose is justified because it has got a concentration dependently. Peak is required, high peak, and it will otherwise stay and in the body for a longer period of time. But for metronidazole, it may not be the case, because it is either concentration dependent or IUC dependent. Now, remember, this is an oversimplification. It is the drug and bug combination and the drug and site combination. Lot of factors come into the play which require simulation, for which a lot of data needs to be generated. But this is a simple take-home message for from today's session. Okay, then we come to the dose modification. How do we need to modify the doses? Now, we are obsessed with TDM levels, whether we modify the doses on the basis of the concentration which has been achieved. We should be modifying the doses on the basis of clinical covariates and both. So presently what is available is, we have nomograms which are available only for aminoglycosides, a couple of aminoglycosides. But those nomograms have got their own drawbacks. They are developed in Western population. They are not, and the rate of infusion has to be perfect. Hartford nomogram that we will see in the next slide, they have got their own limitations. The most important aspect is that you should be using it on the basis of clinical covariates. Now, this whole slide is practically for the pharmacologist and for the research plan, or maybe once we have TDM facility available, you can plan your thesis work on that. This is good for research purpose, but for practical things, you have to think in terms of the clinical outcomes and how do we apply that. Now, there are three pharmacodynamic properties that we have already discussed: concentration dependent killing, time dependent killing, and then comes the issue of post-antibiotic effect. Do we need the antibiotic to be present always in the body to have that? Now, we discussed something about protein binding and the high tissue distribution. For those drugs, switching and discharging the patient, switching to the oral antibiotics and discharging the patient early and de-escalating the therapy makes sense. These principles will help you. The post-antibiotic effect and the persistence of the effect, antibacterial effect, will help you in planning your de-escalation strategy. Look at the drugs which have got high lipid solubility. They will penetrate tissues in a better way. De-escalation can be started early. Once we are concentrated the tissues, they are going to stay. Aminoglycosides have got significant post-antibiotic effect. That is why the concentration is high, and later on post-antibiotic effect continues for days together, even after discontinuation of the drug. Now, What we need to understand is that we want to maximize the drug concentration, we want to maximize the duration of exposure, and we want to maximize the total amount of the drug which is required in a particular clinical situation. I'm not negating the effect, I'm not telling you in terms of pharmacology. I'm telling you assess your patient clearly. Bloodstream infections, sepsis, scoring system, all those things apply. And on the basis of this, on the basis of patient condition, maximize all these things. Maximize ultimately the exposure of the individual to antibiotic. To err on the higher side is right in life-threatening situation. To err on the higher side in outpatient setting is wrong. So err do an error on the higher side in your IBD patients because they are at a life-threatening situation. Don't do it in outpatient settings because immunity will take care of it. And then we come to the use of now again this is the same slide. Aminoglycosides, they have got concentration dependent killing. These are the for these maximizing the drug concentration is relevant. For carbapenems, cephalosporins, erythromycin, beta-lactams, it is the maximizing the duration of exposure is more relevant. For clindamycin and other drugs, vancomycin, it is actually the maximizing the amount of drug. Vancomycin we are using very quite commonly, quite frequently. Vancomycin falls in practically in this category itself, where maximizing the amount of drug is relevant. And definitely it has got narrow therapeutic index. We need to be worried about these areas also. Now, what are the dosing strategies? For concentration dependent killing, definitely it is that the dosing strategies, high doses for aminoglycosides, which optimizes the concentration dependent killing activity. And this is the Hartford nomogram. There are other nomograms also. This is also available. This is available where hours after start of the infusion and the concentration guides what is the probability of success, whether it is in normal range or whether it is the subject is likely to develop ADR. But the applicability in our situation is limited. So for aminoglycosides, they have got a significant post-antibiotic effect. Effect lasts for 2 to 8 hours. That is the post-antibiotic effect. So frequency can be decreased, but the concentration has to be high. The duration of this effect is primarily dependent on the height of, okay. Standard dosing regimes tend to result in relatively low, okay, forget about this text. But ultimately, the idea is for aminoglycosides, higher doses, as over a small duration of infusion is going to be better. But for time-dependent antibiotics, it is the slow, continuous infusions which are going to be helpful in appropriate doses. And again, it is all about time-dependent antibiotics also. Then we come to the use of drug-drug combinations when we are using multiple drugs. What is your take about giving 2 drugs in the same patient? Like we discussed, beta-lactam with aminoglycosides. The question is, you have got a culture report where bacteria is shown to be resistant to, let us say, 6 out of 7 drugs which have been tested. Now, as a treating physician, you have the option of either upgrading your treatment to colistin or ticacycline or depending on the organism, or picking up a combination of antibiotics. Now the choice is between using an individual agent, which is a reserve antibiotic, or exploring the possibility of using drugs in combination. Drugs to which the antibiotic has shown either intermediate sensitivity or it has shown resistance. Which one would you like to explore? You would like to upscale, or you would like to explore the use of combination? In combination. So your take is that we are going to use combination. You are going to explore combination of drugs. These are the 2 possibilities. Ultimately, the patient needs to be cured, and we have 2 options: upgrade the antibiotic to colistin or reserve antibiotics, or explore the combination of antibiotics. How many times you have used actually the combination of antibiotics in your practice? I think you are using quite commonly the antibiotic combinations without thinking without having a logical approach. What is the most commonly used antibiotic combination that you have used? Beta-lactam, piperacillin, tazobactam, and do you include add metronidazole to it also? Piptaz, metronidazole, and aminoglycoside. Amikacin, nahin.
The maximum ICU setup here, what they are using for the combination towards three type of organism, mainly the bacteria. One is the aerobic, one aerobic gram-positive negative, and anaerobic. Usually they combine the present tazobactam plus amikacin and nitrogen or combination.
Now this approach is on the basis of gram staining.
Without staining, it is just empirical.
So this is empirical. Okay, so we can say that it is preventive.
Yeah.
But when we have a specific report,
After report comes, normally de-escalation usually.
and report shows lot of resistance.
Yeah, for report normally they usually still continue the gram positive, like atomizing them started from the gram positive, that also will continue. From gram negative, which 2 is started initially, they will de-escalate to 1 as per the sensitivity.
And what to do in the situation where you have resistance to 6 out of 7 drugs which have been tested?
Also, they will continue the resistance drug plus add cholesterol.
Okay. So basically they will upgrade also and they will add the combination.
Yes.
So dual therapy.
Yes. There is a mixed pattern of
Dual strategy, I would say that. Now, if we look at this logical thinking, resistance is defined on the basis of MIC cutoff points or MPC cutoff points. That after this MIC, the zone of inhibition was not achieved as per the expectation. What happens if we give it in higher concentrations? Can we, the break points which have been defined, can we change that? Or when we use it in combination of another antibiotic, that is why beta-lactam with aminoglycoside combination is there. Beta-lactam will damage the cell wall. Aminoglycoside will increase the penetration of aminoglycoside. So if there is a resistance pattern to any of these, it is going to be taken care of. And rest of whatever is remaining, the body's immune system can take care of that. And whenever you are giving a combination, the better strategy will be rather than upgrading, like I discussed in the hospital pharmacy data, colistin is being used rampantly. Explore other options also in terms of drug combinations. Using a quinolone is a possibility. You can use quinolones and combination. Quinolone, beta-lactam, and aminoglycoside combination makes sense in many cases of resistance. You do not need to upgrade actually, and we are keeping the reserve antibiotics reserve.
And that is also basis for any combination therapy coming, like for HBL infection or the tuberculosis, for the any combination or even ART also. So why combination therapy coming? So one major help for that to prevent the resistance in combination. Otherwise, you could have given a one drug therapy.
So these are the fallacies of MIC-based reporting, and you will have to use your clinical judgment for the best outcomes, treatment outcomes. Now, you can use a high dose in case of intermediate dose, but what about combinations? We are having a discussion about combinations. Combinations are okay. We can have a discussion later on about let's say the fluoroquinolones. They have to penetrate inside the cell, and the bacteria is fluoroquinolone resistant. That means it is not working. It is not responding at a particular concentration. What if we increase the availability inside the cell by giving it with the beta-lactam? If it is target which is altered, if the target alteration is the mechanism of resistance, probably yes, it may not work. But if it is the efflux mechanism which are predominant, the excess of concentration can easily overcome that efflux mechanism. But when we are using it in combination, should we upgrade directly to colistin? The question is that. We are having a discussion.
Also, therefore, our team are suppose you are sending a reference to microbiology, whatever resistance you see, In that actually we know some basic mechanism of the organism versus a drug. Now it is already established actually all the organism in which antibiotic in what way they are taking the resistance. So like Dr. Punitra, suppose it is a efflux mechanism, so we will give the more higher concentration, then combination, let's see whether it is a resistant or sensitive. So once that microbiology in vitro data suggests it is sensitive, then we can use. And till that time actually yes, we can try for another 3 days because before jumping to the higher track like holistic, then we try. And once we see for pilot like 10 cases, then we can implement in our institute. Yes, that will make a cumulative or antibiotic actually in the future part. Because it's, yes, suppose even in 10 cases we are seeing, in 3 cases also we are seeing in vitro data, yes, this combination is working for the E. coli in the case of this resistance. Then ahead we can start empirically equate for this combination. So in this way we progress.
So the idea is keep the reserve antibiotics as reserve. Explore the combinations also and do not just make a decision on the basis of individual report. That is the idea. Use the drugs whenever either using it alone or in combination, use it appropriately as per the pharmacodynamic principle, whether they have concentration dependent killing or time dependent killing. So duration should be, dosing regime should be according to that. And as far as TDM, we have already discussed the take-home messages. It may or may not help the therapy or change. Then duration of. Now, these are the practical considerations that we have already discussed. Concentration-dependent killing, loading dose followed by higher dose, time-dependent killing, prolonged infusions in higher doses for critically ill patients, and for drugs which show a UC to MIC ratio, you can use any of these strategies. We have already discussed these issues, MIC-based dosing principles, previous exposure to antibiotics, multiple. Now, this is another important area which we see in tertiary care setting. Patient is was already on meropenem before he was referred to our center. What to do now? Should we straight away shift on to colistin or maybe the other any other agent that we will discuss? And these are the things which have already been which have been discussed, as at least IV to oral switch has been discussed. Therapeutic index of the drugs again. Most of the antibiotics have got are safe, relatively safe. Drug-drug interactions and the other comorbidities are important considerations which we can take up, and this is actually the domain of clinical pharmacology. Purely research work and a lot of research is possible. Now, key take-home messages: right dosing regime, right dose for right duration, and exploring the combinations before upgrading to the next level of antibiotics is going to help a lot in long run. And use your mind, use your logic. All of us are literate enough, and if you have any problems in exploring the data, literature, reading the literature, we are very ready to. We will be very ready to help you out because we have got time. Putting it simply.
Thank you, Dr. Puneet, for the practical session. And I think all the rest, and when you will practice onwards, you will follow this. The last presentation about our assessment part, because without documentation and without doing research, we were nowhere. Like we have done the research, therefore we are in the good shape. So Dr. Punir leave, so I will take a photo. Just stand up from your place. Because he is the pharmacy in charge, so therefore he cannot give time. Thank you. I request you, Dr. Upendra, to complete the last one. Good.
Okay, so this is the last session, and I will try to keep it as crisp as possible. So it is about the measurement of the processes and the outcome indicators. So basically, what all efforts, what all interventions we have done in an antimicrobial stewardship program. So how do you know whether they are working or not? How will you be like ensuring whether whatever you are doing, is it right, is it going in the right direction or not? So all those things, for how you know, those measures are basically the what I will be talking about. So in like when you talk of the AMS intervention, there are you divide the measures in three broad categories. Those includes the structure measure, which is the measure about the organization or the facility which is there, the leadership, the committee meetings, all those things. Those are because of like those you assess with the help of structure measures. Then you have the process measures. Whatever you are doing, is it in the right direction? So that you assess by the process measures, and then we have the outcome measures. Outcome measures is like, okay, you are doing the interventions, you are providing the feedback, you are trying to minimize the use of the antimicrobial to prevent the use of broad spectrum antibiotics, but this should not come at the cost of negative patient outcomes. Patient should not suffer. So how we will know that? For that we have the outcome measures.
Yes, Dr. Odin, I want to add. And this is main slide for all life your life. Because what I also learned from last 5 or 6 years before from this slide, whenever I am doing anything, like you told, intervention we are doing on daily basis. Every moment is an intervention for a clinician, for a microbiologist, pathologist, anyone. Because once I am seeing something, I am making a diagnosis, making a decision to write something, whether it is investigation or a prescription. So each intervention we are doing on daily basis, how we are assessing ourselves whether we will be better in the future. Because last 6 years of my journey is based on this something. Because I am tracking on this aspect of myself. So any intervention, forget about this antimicrobial stewardship intervention, anything you are doing, even if your research project you will do. So that this thing will apply to yourself. You have to assess which some structure means a policy. Structure. We will go to the detail, but just for briefing to your daily life. So whatever you are doing, so some structure should be there. It means discipline structure, something you have to make. Then you have to do that things. That is the way, and you will get the result. So this is the key thing you will get, and that key thing is repeated by this thing. Structure your policy or your mind knowledge, whatever you are retrieving from your patient, and then you are trying to do that when you are doing some, it is a process. Then you are getting the result. Whether patient is recovered or whether you are getting passed on the exam, whatever. So any intervention in our life, actually these three things apply. Any project in your whole life, you can apply this measurement, that is known as process measurement and outcome measurement, to your all type of intervention. Just now focus on the MSP intervention, what actually you will do.
So, as I said, the structural measures, they are basically to assess the capacity, what facility which we have, and the organization. So, the key questions which we need to ask to introspect about, or how to measure the growth or development of the organization. So for that, you need like, are the governance structures in place? Now, what all could be the governance structures? These could be the committees which we have. So are they conducting a frequent meetings? So record of all those meetings, the minutes of the meeting, are it being held in place? Then the reports which are being given. So these all will help you to will serve as a structural measure for the governance. Then do we have the resources? So the efficient or is there a effective allocation of the staff, of the funds? So all these data, the record of all these things in the antimicrobial committee, that helps you to judge about the resource allocation. And then we have whether we have a policy or not. So do we now a question for you people, do we have the antibiotic policy for our institute? Yes, we do have, and it was like formulated in 2021, so it will be revised in days to come. So these are the measures for structural assessment. Then we have the assessment for the process. So what all measures, what all interventions we are putting up, the day-to-day activities, all those things, that will be the process measures. So now there's a long list for these. For as sir has mentioned, this is not only for the antimicrobial. This is applicable throughout our life. So with regard to the antimicrobial stewardship, again, it is a long list. Now, whatever intervention we are putting up, say the prospective feedback, the antibiotic de-escalation, then the start or what should we say, the streamlining, then intravenous to oral switch. So all these things are individually, they have different indicators. So this is the long list of that. For example, you can we have this 48-hour review measure, which is the number of patients where a 48-hour review is performed divided by the total number of the patients being treated with the antibiotics. Then we have a de-escalation indicator. Same for intravenous to oral switch, there is a indicator. So there is a like this is not only the exhaustive list. There are further more indicators. So these are just some of the examples which I have put. Then so this was the to assess what we have been doing. Then whether the interventions they are working, they are not causing any negative patient outcome. They should not be at expense of patient recovery. So for that we have the outcome measures. So and again, just as we had for process indicators, for outcome measures also, there is a long list, but most important used indications that we have or used indicators or used measures that we have are defined daily dose and day duration of therapy or days of therapy. So these are the two indicators that we use as the measurement of the outcome of the patient. So what is DDD? So there is a classification that is known as ATC, anatomic and therapeutic chemical based classification of the drugs. So this classification system of the drugs, it classifies the drugs on the basis of what organ it is acting upon, that is anatomic, then what is its pharmacological use or the class, that is therapeutic, and its chemical structure. So on the basis of that, ATC has classified the drugs. Now this ATC classification, it was being used by WHO to give to define, like there is a ATC code given to it, just like we have ICD codes, so we have ATC codes also. So WHO used those ATC codes to give a DDD, to calculate a DDD value. Now what is exactly DDD is? DDD is that I'll talk later. So there is a given value of DDD or DDD to the each of the ATC coded drug, and these are calculated as the like in the numerator we have for DDD we have the amount or the consumption of the drug of the antibiotic which is being given to the patient, divided by the denominator it is the patient days. So how do we calculate patient days? That is the number of beds in the given hospital and multiplied by the occupancy index. It may be anything from 0 to 1 or that, and multiplied by the number of days. So this gives the patient days, and this value numerator by denominator multiplied by 1000 will give you the DDD per 1000 patient days. Same goes for days of therapy, DOT. So like DOT, again, it is the number of days for which the patient is given antibiotic regardless of the dose, that is the days of therapy. Again, the obvious limitation is we are not considering the dose, we are just considering the duration of therapy for how long it is given. That makes it a little lesser preferred option than DDD. But again, there is a recommendation that at least 2 matrices, see there is a long list, but at least 2 matrices should be specified to interpret or to comment upon the outcome. So those two we have is these two, DDD and DOT. And another thing is that when we are calculating the days of therapy, so it is not there might be if there is an antibiotic combination. Suppose I'll show example also. Vancomycin and meropenem are being given, but vancomycin was given initially for 3 days or say 5 days. Meropenem is given for some other indication in the same patient, but at a later time period. Now, this duration of days of therapy, it will take into consideration this whole period for which vanco was given and for which meropenem was given. So there will be like you are not actually calculating. You cannot comment upon on a single and when you are using a single when you are using a composite endpoint antibiotic. Okay, so I'll just show you with the example. Then WHO, how does it define the defined daily dose? That is it is the assumed average maintenance dose per day for a drug for its main indication. So it is basically the amount. Days of therapy was the length or was the duration. Here we are taking into consideration the amount of antibiotic that has been prescribed. Now, for every ATC code, one value is assigned by WHO for DDD, and however, it might not be other way around. Like all DDDs, they have ATC code, but all ATC coded drugs should not have, might not be having a defined DDD. And for every drug or every ATC coded drug, only one DDD can be assigned. But again, DDD, it does not correspond with what is the prescribed daily dose. For example, vancomycin is given 500 milligram twice daily. So prescribed daily dose is 1 gram. But that might not correlate what the DDD might be, say 2.22. So it is not correlating with what is being prescribed daily. So that is a prescribed daily dose. Okay, so but what is the use of these indicators? These provide you with the fixed unit of measurement. You have something to compare with. You can make comparison with your institute data with other institutes. Even international comparisons are made on the basis of DOT and DDD, and these are basically utilized for the drug utilization studies where you want to assess the consumption of the antibiotics in the particular settings. So this is the just a hypothetical example. So here you can see that the 3 patients, they are given vancomycin 1 gram IV every 12 hours for 5 days and meropenem 1 gram IV every 8 hours for 7 days. So similarly, the patient 2 and patient 3, all of them, they are being given vancomycin and meropenem. So if I have to calculate the defined daily dose DDD, how I will proceed about that? So in the numerator, it will be the amount of the drug. So now what amount, the total amount that has been prescribed, and it is calculated for the the ATC coded drug. So vancomycin will have a different code, meropenem will have a different code. So for vancomycin, for meropenem, suppose total amount which is being given is, see here, it was 1 gram every 8 hourly. So it becomes 3 grams per day, and for 20, so it will be 21 something. So same for this, and it has combined or summed up the total dose that comes somewhere about 83 gram. So this is the dose divided by this 2 gram is the WHO standard. WHO has given a DDD value for every drug. So that for meropenem it is 2 gram in this case, and that divided by the patient volume. Now patient volume, what I said, how you calculate the patient days, the number of beds into occupancy index. So that will give you the patient volume. So that multiplied by a factor of 1000, or it can be 100 also. Commonly we use 1000. So that will give you a value of 207.5 DDD per 1000 patient days. Same for vancomycin. we get the 85 DDD per 1000 patient days. But here you can see what we are getting. It is not 85 DDD is not correlating what you prescribe daily. Vancomycin is 500 milligram BD, as I said, or it can vary. Then days of here we have taken into consideration the amount of antimicrobial that is given. In days of therapy, the antimicrobial days is being considered. So here vancomycin was given for 22 days in total. So simply putting up into the formula, we get the 110 days of therapy, and same for meropenem. So these can be compared, this data will be different for different institutes, and that can be utilized for making the comparisons. Now here there is another thing, length of therapy, LOT. So this length of therapy, it is a little complicated thing, because here you have to take into consideration every individual duration of the treatment. For patient 1, the 7 days, 2, 10 days. So here you are summing up whole of this, and so it does not, in nutshell, it does not serve that purpose. So sometimes it is being used as a process indicator, sometimes it is being referred to as an outcome indicator. However, what the take home is, or what is important to know is that these two are the parameters that we use for making the, or for judging, for assessing the outcome and for making the comparisons. And apart from that, what else could be a better outcome than the patient outcome itself? You can have the in-hospital mortality rate that you can calculate, or the readmission within the 30 days after discharge. So these can serve as important outcome indicators for the whether the patient is improving or not. Then again, you can have microbiology based outcomes also. You can calculate the rate of occurrence of or the prevalence of the Clostridium difficile infection, or because when you use antimicrobial, how will you know whether about the resistance pattern? So that you can assess by calculating these outcomes. So either Clostridium difficile infection or MDR organisms like MRSA, extended spectrum beta lactamase, or carbapenemase. So these rate of these infections you can calculate per total number of patient days and multiplied by, here the factor becomes 1 lakh. So that you can use. So, and the data you have pharmacy dispensing, how you will know, how you will calculate these indicators. So these are the data sources that you can use. So that ends the presentation basically. So you had see, if you go in much detail, there are lots and lots of indicators which are given in the literature, but ultimately these are the ones which are commonly used and importantly being used for the research purposes also, and by the WHO and ICMR. So that is why I have used this. So thank you.
Thank you, Dr.
Okay, any question on this? Because this structure, process and outcome measurements, everything you also use in your thesis. Whenever you are getting a project, always there will be outcome variables. And now fill this actually barcode, because this is mandatory. And also fill the barcode. Please fill that barcode for the last time. And I think all of you have filled in the day before yesterday also. Because it will assess, it will give you for me, the one work I need from after you are filling, because I have to identify a best resident who scored the maximum. Because I have to give the award to him from the AMSP team or from the WAAW. Because in this we are giving IAS champion to the nursing officer. We did a questionnaire based assessment, and also HA, HK, and also resident. Resident is both same for, because we have taken first and second semester, whether it is MD, DM, and CH or MS. So, and based on the 3 days data, we will give not only 1 day. And last 2 days, if someone has submitted, please submit now only. It will take only 10 to 5 minutes like that, because if you have attended something or even if not attended some one class like one session, you can fill that. And everything is there in the WhatsApp group, I think. This is the today session. Yesterday session is already there previously, and the day before session. And yesterday, how many not filled or all filled? गूगल फॉर्म में रेस्पॉन्स में देख सकते हैं ना कितना कॉल गूगल फॉर्म ओपन करके देख